We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Pinnacle News Series. And today's topic is menstrual bleeding in association with Roorkee, Halwani, Sevagram, Kohima, Gandhinglach, Wayanad, OBGYN societies. So let us start the webinar with prayer song. It's my privilege to introduce the MC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician from Salem and treasurer of Salem chapter of Tapisa. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Sahiti. A very warm welcome to one and all. I'm extremely privileged to invite the respected presidents and secretaries of Roorkee Society, Dr. Aba and Dr. Preeti, Haldwani Society, Dr. Madhukiran and Dr. Gunjan, and Sevagram Society, Dr. Poonam and Dr. Shilpa, Kohima Society, Dr. Kevalhonyu and Dr. Teja Vinu, and Gatingla Society, Dr. Pratima Chavan and Dr. Supriya, Wayanad Society, Dr. Omana and Dr. Shivakumar. So this webinar series is the Pinnacle News webinar series occurring every alternate week, and today it covers heavy menstrual bleeding. So this is organized by Professor Dr. Sampath Kumari ma'am. Can I have ma'am slide please? Ma'am is the professor and HOD at Sri Muthukumaran Medical College at Chennai, and she was the past vice president of Foxy and also the Senate member of Tamil Nadu Dr. MGR Medical University. And ma'am is also the current president of Oxy, and also she's received she has numerous awards to her credit. So, and actually, ma'am is in flight now, and she'll be joining us in a while. So we have. So now I seek blessings of our respected chief guest. Can I have the slides, please? Dr. Bernadette ma'am, who's a PG teacher at Gatinklaj in Kolhapur, and she's also the medical director of Maher Multispecialty Hospital, Ajara, and she has special interest in preventive oncology, high-risk pregnancy, and ultrasound. Thank you so much for joining, ma'am. Over to you for your words and blessings.
Thank you, ma'am. Thank you.
Yeah, I'm able to hear, ma'am.
Yeah, I'm so excited to be joining this, and thank you so much, Madhumita and Dr. Sampath Kumari for giving me this opportunity. I also like to thank Dr. Pratibha Chavan, who is the president of our society, who has given me this opportunity to take part in this webinar on heavy menstrual bleeding and postmenopausal bleeding.
Thank you so much, ma'am. It's an honor to have you here with us today. I welcome our respected guest of honor, Dr. Pratibha Chavan, who is the president of Gatin Class Society. Over to you for your kind words, ma'am.
On the behalf of Gadinglas OBGY Society, I am audible.
Yes, ma'am. Yes, ma'am.
Thank you for our three society members making a part of this webinar series. Thank you. Thank you,
so
Sampat
much.
Kumari Madam and Madhumita Madam.
Thank you so much, ma'am. We are so grateful for your presence today, ma'am. For our next guest of honor, Dr. Poonam Verma, who is the president of Sevagram Society and professor of OG at Kasturiba Hospital. Ma'am, Poonam ma'am. Poonam ma'am is there? I think ma'am will be joining in some time. I invite our next guest of honor, Dr. Madhu Kiran.
Hello, everyone. And I'm also very excited to be a part of this webinar. And thank you, Dr. Shanta and her team to involve me in this webinar. Thank you, everyone.
Thank you so much, ma'am. Thank you so much for your time and your presence, ma'am. Thank you so much, ma'am. So moving on to our first session, we have a talk by Dr. Meena Mahalingam. And we have our chairperson, Dr. Kevilhonu Linyu. Sorry, sir, the pronunciation is wrong. Who's the president of Kohima Society. And we have our next chairperson, Dr. Abba, who is the president of Roorkee Society and who's also the head and director of Kasturi Nursing Home. Ma'am, can you introduce Dr. Meena Mahalingam, ma'am? Abba, ma'am. Ma'am, is yours.
Audible?
Yes, ma'am. Yes, ma'am. You're audible. Abba, ma'am?
Yeah.
Yes, ma'am. Yes, ma'am.
इंट्रोड्यूस करना ना मैम को
Yes, ma'am. Yes, ma'am.
या ये थोड़ा नेट प्रॉब्लम आज का मैम डॉक्टर बीना महिंगा मैम हेलो मैम नमस्कार am I audible?
Yes, ma'am. Yes, ma'am. You're audible.
Yes, ma'am. Namaskar, ma'am.
Dr. Meena ma'am namaskar. Ma'am is MD
Namaskar, ma'am.
DGDNB, MRCOG, FICOG, MN AMS, Obs and Gynae, Associate Professor in Obs and Gynae, and Pinnacle Medical College, Pinnacle 2. Sorry, pronunciation. Secretary, Obs and Gynae SSI, Co-Chair, Urogynae Committee, OG-SSI, member of Urogynae Subcommittee, FOXY. Special training, urogynecology, microsurgery, endoscopy, instructor, basic newborn care and resuscitation program under IAP. Clinical experience of 23 years in tertiary care teaching institute. Academically, master training on NC, faculty and organizing member in national and international conference. Membership
Abba,
OXY, IUGA, URPSI, CMS, ATNROGS, and research 8 publication including 5 original articles. Community participation or adolescent health camp, blood bank camp, district instructor in IAP, NRP, FGM training of HCW in NRP. And received many scholarship from IUGA for attending IUGA conference in Italy, Best Doctor Award 2024, and won awards for scientific paper presentation. Thank you, ma'am.
Thank you so much for the introduction, ma'am. Over to you, Meena, ma'am.
Thank you, madam. Thank you, chairpersons. Thank you, Sampath, ma'am. Thank you, Madhumita, Arun, Karthik, Sahiti. As I'm traveling, I request Sahiti to project the slides. As madam couldn't join, I'm taking over this lecture. So madam will be joining shortly. So my topic is management of abnormal uterine bleeding in adolescent or the young girls. Next. So I would be taking the topic as different terminologies and the different definitions and the palm coin classifications, recommendations for the diagnostic workup and recommendations and management guidelines for abnormal uterine bleeding in these young women. As we all know, it is very challenging and it is also a neglected problem in adolescence, as it has got negative impact on quality of life, and it is a huge financial burden not only on the adolescent girl but on the health system and the country's economy. So also we see that there is an inconsistency in the management of AUB in day-to-day clinical practice. That is why we are here to discuss about this. So normal menstruation, we need to know the cycle length, the cycle predictability, the duration and the volume of flow in these young girls. 4 key dimensions about regularity of menstruation, whether it is irregular, regular, or absence of regularity, frequency of menstruation, whether it is frequent, normal, or infrequent, duration of menstrual flow, whether it is prolonged, normal, or shortened cycle, and volume of menstrual flow, whether it is heavy flow, normal, or light flow. Next. So, educating the mother and the daughter is very important to deal AUB in the adolescent girls. So initial assessment of AUB is more difficult. We need to know about the cycle to cycle variability in these young girls, differences in the menstrual hygiene patterns, whether she uses a towel cloth or a sanitary pad or the menstrual cups. The menstrual hygiene products which is available in their society, inconsistency in giving information about menstrual regularity and bleeding is to be understood. Perception of normal menstrual cycle may vary in girls and their families. Patients may not inform their families about menstrual irregularities. It may be a symptom of something else which we have not diagnosed. So there are many period trackers which are available in our internet. We can have it as a WhatsApp working system as well. Next. Now, palm coin classification. What is it and is it necessary for these young girls? So as we all know, the PALM, the abnormal uterine bleeding, has got 4 components. That is, it is a discrete structural entity that can be measured visually with imaging techniques and or histopathology. The coin is 4 components which are related to entities not defined by imaging or histopathology, meaning to say they are non-structural. One component is not defined at all. So coming to the PALM classification. Next. So the structural component wherein we are able to observe a polyp by imaging or a hysteroscopy, adenomyosis, leiomyoma, whether it be a submucosal or subserous or an interstitial, malignancy and hyperplasia. Coin classification where it is a non-structural entity where we do not have any structural abnormalities by imaging. We do have a coagulopathy, O is ovulatory dysfunction, E is endometrial pathology, I is iatrogenic, and not yet classified, wherein we deal with arteriovenous malformation and intramyometrial hypertrophy. Next. So common gynecological causes in adolescence, mainly what we deal is the anovulation due to the immature hypothalamo-pituitary ovarian axis, infections, trauma, and endometriosis. Next. Sahiti, next. Non-gynecological causes like coagulation disorders, wherein we have the autosomal dominant von Willebrand's disease, idiopathic thrombocytopenia, factor deficiencies, iatrogenic causes using exogenous hormones, and some medications which can also have a role in causing AUB in these young girls. AUB is not a diagnosis, but either it is a symptom or sign defined as any variation from the normal menstrual cycle. It includes changes in regularity and frequency of menses, in duration of flow, or in amount of blood loss. It is subdivided based on the volume of menstruation, regularity, frequency, duration, chronicity, and timing related to reproductive status. So, what are the terminologies which are generally accepted? We do call it as abnormal uterine bleeding AUB, acute and chronic AUB, heavy menstrual bleeding HMB, HPMB is heavy and prolonged menstrual bleeding, IMB is intermenstrual bleeding, PMB is postmenopausal bleeding. These are the terminologies which are generally accepted in AUB. Next. So acute and chronic AUB. Acute AUB is an episode of bleeding in a girl of reproductive age that is of sufficient quantity to require immediate intervention to prevent further blood loss. Chronic is when the bleeding that is abnormal in duration, volume, and of frequency and has been present for at least 3 months. Heavy menstrual bleeding, that is excessive menstrual blood loss, which interferes with the girl's quality of life. Next. So, what are the diagnostic workup recommendations in these young girls? Next. So, normal menstrual cycle. So, we need to know what is normal to identify what is abnormal. So, use the menstrual cycle as a vital sign. During the first 2 years after menarche, because of the immaturity of the hypothalamic pituitary ovarian axis, the cycles may be irregular, but 90% of the girls usually have cycles in the range of 21 to 42 days. Mean is around 32.2 days. Flow length can last between 2 to 8 days. Mean is around 7 days. Interval between menarche and regular cycles is about 14 months. Mean product use is 3 to 6 pads or tampons per day. Next. So we need to evaluate if the cycles are persistently less than 21 days or greater than 45 days. Cycles are initially regular, then become irregular. Flow lasts more than 7 days. Patient tells you she is bleeding too heavily, generally if she changes more frequently than every 2 hours. So it's all in the history. Then comes the examination. In the history, taking a full menstrual history, starting from age of menarche, frequency, duration, and the number of days, sanitary pads used per day, how many days has the current bleeding lasted, the anemia symptoms, and medical history to rule out other bleeding disorders, which we have already mentioned, like von Willebrand's or idiopathic thrombocytopenic purpura. So, detailed history, if there is a prior use of hormonal contraceptives, which can be iatrogenic cause, and importantly, to identify sexual activity in these young girls. It is very important to take a sensitive and confidential history in privacy, asking the girl to be alone with us during history taking so that she is able to share the sexual part of the history to us. History of dysmenorrhea, use of seizure medication, liver, kidney, gallbladder disease, history of malignancy, psychosocial interview to assess for major stressors which may trigger bleeding. Next. So, what are the recommendations? Abandon the old overlapping terminology and use the Palm-Cohen classification for the diagnosis of abnormal uterine bleeding. Obtain a thorough history and conduct a physical examination if needed to detect the need for further investigations and treatment. Obtain information about concomitant use of any other medications which can cause abnormal uterine bleeding, which could be the cause in this, and just avoiding the trigger of using these medications will help the girls get cured of the symptom. Next. So, what are the screening done for bleeding disorders? Whenever there is a heavy menstrual bleeding since menarche, or if nowadays even we see girls delivering very young, they have a postpartum hemorrhage in their adolescent age, after delivery or surgery related bleeding, bleeding associated with dental work, or two more of the following symptoms like bruising 1 or 2 times in a month, epistaxis 1 or 2 times a month, frequent gum bleeding, family history of bleeding disorders. Next. So, coming to the red flags, prolonged bleeding from trivial wounds lasting more than 15 minutes, or whenever there is a recurring spontaneously within 7 days. Blood in the stool unexplained by anatomic lesions such as stomach ulcers or colonic polyps, anemia requiring treatment, or if there is a need for blood transfusion, heavy menses characterized by clots greater than an inch in diameter, on a changing a pad or tampon more than an hour, or resulting in anemia low iron stores. Next. Now, coming to the focused examination, generally we check the vital signs, including orthostatic pulse and blood pressure. Look for the pallor in the skin, bruising, petechiae, acanthosis nigricans, to look for also a concomitant screening for polycystic ovarian syndrome like acne, hirsutism. Neck, check for thyroid swelling. Breast, look for Tanner staging. Abdomen, look for any distension. Stria, palpable mass. External genital urinary examination for bleeding source, volume, trauma, and sexual maturity. It is not necessary to perform an internal pelvic examination unless there is an internal vaginal trauma. Laceration is suspected by the history. Recently, we had a bulgur injury where in a nulliparous women we had to examine and suture. So it is important based on the history, we need to do a local genital urinary examination. Recommendations in the initial examination, it is important to check for the weight, pallor, and thyroid, breast, acne, and hirsutism. If present, we need to clearly document. Abdominal examination, speculum and pelvic examination indicated only if the woman is or the girl is sexually active. Next. Sahiti, next. Sahiti. So first line blood test. And, yeah. First line blood test. Usually we try and do a pregnancy test. Disorders of pregnancy like missed miscarriage or incomplete miscarriage or a complete miscarriage. Complete blood count with differential count to check for anemia, if there is a microcytosis or thrombocytopenia or a pancytopenia. Ferritin to look for iron deficiency. Prothrombin time to look for factor 7 deficiency if it is prolonged. And activated partial thromboplastin time. Generally, we do check for factor 8, 9, 11, and 12 deficiencies if prolonged. And also, this APDT will be prolonged in von Willebrand's disease. Thrombin time and fibrinogen to look for hypofibrinogenemia, apparent contamination if prolonged. Von Willebrand antigen generally is deficient in von Willebrand. Type and screen and cross match. If profoundly anemic, we may need to give her a blood transfusion. Next. Sahiti. Second and third tier of investigations after we have done with the first line investigation to look for other causes like sexually transmitted infection, ruling out chlamydia, gonorrhea, vaginal, cervical, and urine testing. Thyroid stimulating hormone to look for thyroid abnormality. Generally, if there is a hypothyroidism, these girls tend to bleed more. And total free testosterone and dehydroepiandrosterone and androstenedione to look for polycystic ovarian syndrome workup. Von Willebrand profile, looking for von Willebrand antigen activity, ristochitin cofactor assay, factor assay, and multimer analysis to look for von Willebrand disease. Liver function test also to be done as a second tier to look for liver disease causing coagulopathy, platelet function and aggregation testing in case there is a platelet aggregation and secretion disorder. Next. Ultrasound can provide information about endometrial thickness, can pick up Mullerian anomalies, leiomyoma are uncommon, which can also occur, may identify an estrogen producing malignancy. Ultrasound does not change the management. Do not delay treatment just working for these results. We can start the treatment, that is to stop the bleeding in these young girls. So the recommendations for ultrasound is mandatory to evaluate uterus, adnexa, and endometrial thickness, Doppler in suspected arteriovenous malformation, malignancy, and to differentiate between fibroid and adenomyosis. 3D ultrasound for evaluating intramyometrial lesion in selected patients for fibroid mapping. So what is the treatment for these anovulatory bleeding? Next. Abnormal bleeding in anovulatory cycles are mainly due to unopposed estrogen due to impaired negative feedback of the hypothalamo-pituitary ovarian axis. When there is a dilatation of the spiral arterioles, abnormal endometrial height without a structural support, there is spontaneous superficial shedding of the endometrium. There will be a random asynchronous bleeding in these young girls. Next. So, continued estrogen elevation, decreased follicle stimulating hormone, collapse of the thickened hyperplastic endometrium leading to heavy menstrual bleeding. So mild to moderate symptoms, we generally start them on combined oral contraceptives. Use pill with at least 30 microgram of ethinyl estradiol and preferably levonorgestrel or norgestrel. We do have this Mala N and Mala D. In our government sector, we do give them Mala N, which is free of cost. Counsel that the first menses on oral contraceptives may be heavy, but will get lighter in subsequent months. Iron supplementation to be given at least for 3 months to restore the iron storage. Next. In heavy bleeding, but when the hemoglobin is more than 8 grams and the patient is hemodynamically stable, start oral contraceptives, TDS for 3 days, followed by a BD dose for 3 days, then once daily for at least 21 days. If breakthrough occurs when weaned to OD dose, maintain at BD dose for 21 days, allow bleed, then restart oral contraceptives. Check hemoglobin before allowing withdrawal bleeding. Consider continuous oral contraceptive use so that she doesn't have withdrawal if the bleeding is heavy. Continue oral contraceptives at least for 6 months. Those cycles following the oral contraceptives are generally lighter and they are very managed easily. Symptomatically, they feel better. Next. So, hospitalization is required if the hemoglobin is less than 8 grams, when the girl is having low BP or there is tachycardia, active bleeding is there, volume expansion with crystalloids are given before we start blood. Transfuse blood only for severe symptoms and not for low hemoglobin in otherwise healthy patients. Healthy adolescents can tolerate hemoglobin of 7 grams and recover well as long as bleeding stops and iron therapy is initiated. Next. So hormonal therapy in heavy menstrual bleeding is 50 microgram ethinyl estradiol, norgestrol combination. Can use every 6 hours to stop bleeding, then put them on a TDS dose, then BD dose. If unable to tolerate orally, we can use conjugated equine ethinyl estradiol, 25 milligram IV if available, 4 to 6 hourly for 4 to 6 doses. We have not tried this, but initially we were told to just try a high dose estrogen combination as an intravenous dose, which we have not tried. Arrest bleeding in 90% of the time. Switch to oral contraceptives when bleeding has stopped. Continue oral contraceptives for at least 6 months. Hemostatic on endothelial cells increases circulating factors 8, 7, and fibrinogen. High dose estrogen causes nausea, so we may need to combine with the antiemetic like ondansetron. Hormonal therapy in HMB, if unable to tolerate estrogen or it is contraindicated, norethindrone acetate 5 to 10 mg orally every 6 hours is tried. Medroxyprogesterone 10 to 20 mg orally every 6 to 12 hours, maximum of 80 mg per day. Avoid dipomedroxyprogesterone. It can't be titrated. It is contraindicated in women less than 18 years of age. Next. So what about antifibrinolytics? In heavy menstrual bleeding associated with an increase in local fibrinolysis due to elevated levels of endometrium derived plasmin and plasminogen activators. The plasmin activity is increased in menstrual fluid in women with HMB compared to normal women and correlates with the blood loss. So antifibrinolytics, they interfere with the ability of the plasmin to lyse the clot and decreases the tissue plasminogen activator. So tranexamic acid is safe to use even when we are giving with the combined oral contraceptives. Next. So what about use of LNG IUS in adolescents? It is rarely used in our country as a first line, requires counseling and anesthesia setup for adolescents, and ACOG and AAP recommends its use in adolescents. Risk of PID is increased only at the time of insertion. Document chlamydia and gonorrhea results prior to insertion and treat infections. Next. So the most studied LNG IUS delivers 20 microgram per day directly to the endometrium. The stem contains 52 milligram of the levonorgestrel. Greater reduction in menstrual blood loss is seen 86 to 97% than oral contraceptives, 40 to 50%, and tranexamic acid as same as OCs, and NSAIDs around 20 to 30% reduction. It is shown to be effective in reducing bleeding in postmenarcheal girls with bleeding disorders. Next. Endometritis in adolescent may be due to sexually transmitted infection, backdoor abortions, incomplete treatment of infections. Endometriosis in adolescents, true incidence is unknown as there is often a 10-year delay between onset of symptoms and diagnosis. Up to 69 to 73% of adolescents who do not respond to medical treatment of dysmenorrhea and pelvic pain have been found to have endometriosis at laparoscopy. Next. Trauma due to sexual activity, experimentation with foreign objects, other trauma, and we need to remember POXO, the protection of children from sexual offenses. Nowadays, it is quite common. Make your clinic adolescent friendly. Have a privacy to talk with these young girls. Put posters, flyers, and reading materials. During the waiting time, they can read and come and ask us the doubts. Separate timings for these adolescent girls and be adolescent friendly always, so that they open up their problem to us. Next. So, what are the recommendations? Next. So, coin general recommendations: tranexamic acid is the first line therapy. Other non-hormonal option is NSAID. Combined oral contraceptives are recommended as second line therapy in patients desiring effective contraception but unwilling or unsuitable for LNGIUS. Cyclic oral progestogens from day 5 to day 26 are recommended if combined oral contraceptives are contraindicated in women during contraception. LNG in women desiring contraception, LNGIUS is recommended. Next. Next. So combined for ovulatory dysfunction, AUBO, COCs as first line for 6 to 12 months. Option of LNGIUS for at least 1 year. Norethistron cyclically for 21 days as initial therapy in acute episodes of bleeding for short term of 3 months. In adolescents with AUBO, both hormonal and non-hormonal therapies can be prescribed. Next. So endometrial causes AUBE usually presents with heavy menstrual bleeding, which may indicate disorder of endometrial hemostasis. May present with intermenstrual bleeding, which may be secondary to inflammation or infection. Guidelines are similar to the abnormal uterine bleeding of the ovulatory dysfunction type. Next. So iatrogenic, as we all know, it could be due to the intrauterine contraceptive device or the exogenous gonadal steroids and other agents that affect the blood coagulation or ovulation. Whenever possible, medications causing AUB should be changed to alternatives. If no alternatives are available, LNGIUS is recommended. Bleeding from anticoagulation therapy is listed under AUBC rather than AUBI. That is meaning to say coagulopathy. The key points are AUB is a common problem which has adverse effects on adolescents' quality of life. The most common underlying condition in AUB in adolescent is anovulation. During the evaluation, pregnancy, trauma, and STI must be ruled out regardless of history. AUB during adolescence may be the first sign of underlying bleeding disorders. So it is very, very important to evaluate them, catch them young. Although observation is sufficient in mild cases, life-threatening bleeding may necessitate the use of high dose of combined oral contraceptives, intravenous estrogen, and/or interventional procedures. Next. So these are my references. These are from the FOGSI guidelines, the RCOG guideline, the ACOG committee opinion 2019, an approach to AUB in adolescents clinical endocrinology article. I thank Pinnacle series for having given this wonderful opportunity. Thank the chairpersons, Sampath Kumari Madam and Madhumita Arun Karthik. Thank you. Over to the chairpersons.
Abha ma'am, you're here. Pratibha ma'am, can you give share your opinion, ma'am? Yes, ma'am.
Very nicely, everything about the AUB is explained by Meena ma'am. One thing I want to add, before 16 years of age, usually progesterones are prescribed instead of combined OC pills. We have to think about the bone growth and height of the that particular girl. That's why we in our practice we are prescribing before 16 weeks progesterone in tapering doses, and in case of if the girl is more than 16, 17, 18, then we are giving the combined pills, and we are giving only blood transfusion if the girl is 4 or 5 gram HB hemoglobin percentage. Shall I share my experience?
Yes, ma'am. Sure, ma'am. Yes, ma'am.
Last 1.5 years, we reached around 9,000 girls in our area, school and colleges, around more than 9,000 girls, school and college. Because many times these adolescent girls are coming with 4-5 hemoglobin. That's why our 3-4-5 members, we are going in together, and we are explaining about the anatomy as well as the normal and abnormal menstrual pattern. And after that, we are going one up member by anemia and counseling about the diet. another one for the self-defense. We are giving now sexual education. We are working in the very remote area, rural area. That's why we are reaching as many as schools and colleges, and definitely it helps to the girls. And that time we are also inviting mother parents also. Some few parents may come, but we are telling the girls, you should go and tell this to your mother also. That's why there is awareness is nowadays created. So many times we are taking hemoglobin camp, and that is also means very helpful for them.
That's great, ma'am. That's great work. Thank you so much for sharing your opinion with us, ma'am.
I have a question, Dr. Vibha Mehrotra this side.
Yes, ma'am. Yes, ma'am. Please.
I just want to ask that ma'am told ki anemia is like 4 to 5 gram of hemoglobin. What is the age group, ma'am? I want to ask you, and
Only
why? What
adolescent
is the
girls.
okay? So what is the reason behind so much of less hemoglobin? Why are they not aware of this thing that they
Yeah,
are being
that's why
anemic?
we
Or
are.
what?
That's why we are going towards the school and colleges. Why this is happening? In one school, in very well in Taluka place, we did hemoglobin camp, and that time we did around 300 hemoglobin checkup out of 1,500 girls. By clinically observing, they are looking pale, and out of that 300, around 80 girls were less than 6. That was shocking for me. And after that, we
Yeah.
started reaching towards the girls. Means they are not
Okay.
aware. They don't know when to go to the consult the gynecologist. That's why while explaining in our lecture, we are giving 2 hours for each school. And that time we are explaining them the abnormal menses and what sort of the bleeding is abnormal, and when to you consult your doctor, the gynecologist, and when to do the sonography. That's the thing. It's very common in our area.
Very common.
Monthly, I am admitting around 2 to 3 adolescent girls, 13, 14, 15, 16 age, 4, 5 hemoglobin. And that is because of an ovulatory cycle or many other causes, hormonal DUB mostly, and very rarely pregnancy also.
Okay.
And that's why
Here in our scenario, we do have lot of cases of pregnancies, madam, 12,
Yeah.
13, 14, and
That is also there.
they do have mainly reproductive health issues.
And nowadays diet is also changed. They are not eating properly.
That is what I want to speak. Main is lifestyle modification.
Lifestyle modification is very important.
Yeah.
Some
Yeah,
are
that
very
is-
thin and some are very obese.
Yeah. That is
That's
the
why
thing.
we are explaining about the diet also.
Okay.
And that is beneficial also. And after our lectures, many these girls are coming to our OPD to take opinion.
So, ma'am, what is the exact topic you are covering in schools and colleges? It is
Initially,
anemia
we
or
are taking
AUD?
that uterus with ovaries model. We are giving them in short anatomy. After that, we are explaining them the normal menstrual cycle and
Okay.
what is the abnormal cycle, how much should be lost, and how should if it is how much is the extra, then when to you have to contact about the PID also, as well as after that
Okay.
we are giving them the HPV awareness one lecture, vaccination awareness. After that, we are our team is there. 4, 5 girls are there from my nursing college, and we are giving
Okay.
them self defense demo also. After that, one of our member will give the advice about the simple dietary things and what to eat, what
Okay.
not to eat.
Okay.
We
ठीक
do
है.
have adolescent health slides among 8
Yeah,
topics
that's
are
on that.
covered.
Yeah. That is what my question is, that if I want to go in a school, so we have some slides for that, because I'm taking also
Yes.
for cervical cancer and PCOS. But if we'll be provided with slides, it will be easier for us.
Yeah, in Foxy, we do have this
HPV and all
adolescent
those we have
slides
slides.
for boys and girls. So we can
So, ma'am,
take.
so you can share in this those slides so that it will be easier for us, because I also used to go to
Yeah.
schools and colleges for this
We
program.
have this
That is why.
HPV vaccination and awareness, and all HPV slides are there with us. And other things we are talking just like the normal information. But we require, our 3-4 members require 2 hours for that conversation.
Okay.
Yes, ma'am. Sure.
Okay, thank you, ma'am. Thank you so much.
Thank you.
Thank you so much,
Thank you.
everyone. So at the end of this wonderful talk, now we move on to our session 2. We have a very interesting panel on postmenopausal bleeding, moderated by none other than Dr. Meera Raghavan. Ma'am is a senior consultant, urogynecologist, and robotic surgeon at Chennai. And she's also the convener for TNFOG certificate course in urogynecology. And she's also board certified lifestyle medicine physician, specialist committee member. And she's also the And she's a scientific chair of AICC RCOG 2025, and she's a MRCOG trainer and examiner. And we have our expert for the panel, Dr. Mona Madhusudan, who's the president of Wayanad Obstetric and Gynecological Society, and who's a consultant at Vinayaka Hospital, Sultan Batheri in Wayanad. And we have our esteemed panelists, Dr. Vandana Grover, who's a senior gynecologist at Roorkee, and who has been practicing in Roorkee for more than 35 years. Next, we have Dr. Nisha Marhata, who's a gynecologist, laparoscopic surgeon, consultant, and cosmetic gynecologist, and she's also has 10 years plus of experience, and she's been working in Nainital. Next. Sati, next slide, please. We have Dr. Pallavi Srivastava, who's the center head at Seeds of Innocent IVF Center at Haldwani. Dr. Shilpa Raut, who's a private practitioner at Varda and also the secretary of Sevagram Obstetric and Gynecological Society. Dr. Suchi Jain, who is a professor and HOD at Sevagram, and she's also the past president of Sevagram Varda Obstetric and Gynecological Society. Next, we have Dr. Sati, slide change, please. Dr. Ashimira, who is a consultant at Vinayaka Hospital at Sultan Batheri at Wayanad, Kerala. Dr. Khatija Sherin, who is a junior consultant at Vinayaka Jyoti Hospital at Manantavadi. Next, Dr. Divya Chandrasekhar, who's been in government service at Muthukumar Medical College as assistant professor. Dr. Mahja Bean, who is currently the associate professor and at Sri Lalitambika Medical College and Hospital at Chennai. Over to you, Meera ma'am. Ma'am, you're muted, ma'am.
Yes.
Thank you, Madhumita. Thank you very much. Can we mute everybody except the panelists so that it's easier? Otherwise, there's too much noise.
Sahati, can you mute everyone except the panelists?
Okay.
Thank you, Pinnacle series and Sampath Kumari ma'am for this opportunity. We're going to have a very interactive panel discussion about postmenopausal bleeding. So today's topic is that for the panel. I would like to request Dr. Vandana Grover to take on this question of how we define menopause and define postmenopausal bleeding before we proceed.
Yeah, good evening, everyone. And I would like to thank the organizers for involving me in this very important topic of discussion. Menopause, as you all know, is defined as a permanent cessation of menstruation and for 12 consecutive months. It may be natural or iatrogenic, as natural when with the age between 45 to 55 years, and iatrogenic can be because of the surgical removal of ovaries or other agents like chemotherapy and radiotherapy in cases of malignancy. And the postmenopausal period is defined as that any bleeding which is occurring, postmenopausal bleeding is any bleeding occurring 12 months after the menopause. Whether the menopause was natural or iatrogenic is immaterial. But any bleeding occurring 6 months after the menopause should be investigated. That is the basic.
Yeah. Thank you, ma'am, for that. Because it is not age-related thing, because the average age of menopause is an arbitrary thing which has been in observed studies between 46 years of age in Indian women up to the age of 51. However, it is recommended that we start investigating any vaginal bleed that occurs 6 months after the last menstrual period. Very, very important in younger patients, because our incidence of premature menopause is also increasing. So that should be borne in mind. Dr. Nisha Marhata, could you go through the FIGO classification and its relevance to the postmenopausal bleeding, which we are going to discuss? Dr. Nisha? Is Dr. Nisha there? Can we ask Dr. Majabin to take this question? A FIGO classification of AUB and its relevance to postmenopausal bleeding. Anyone else can volunteer?
Yes, ma'am. Thank you for the opportunity. I'm just traveling. Palm Cohen classification is the classification which we are going to follow, even also for the postmenopausal bleeding. So,
which would be the most important? I'm sure because of the travel, the net connectivity is not great.
Yes.
Can we pass on the question to someone else? Dr. Khadija, if you're not traveling, can you take that question? What aspects of the Palm Cohen would be relevant to this particular situation of postmenopausal bleeding?
Yeah. Yes, ma'am.
Thank you for that. Yeah.
Ma'am, those of concern in the postmenopausal bleeding would mainly that one thing would be that of a polyp, that is P of palm coin. Polyp, because though it can be found like about 6 to 10% in case of postmenopausal bleeding, there is a chance for a malignant change also.
Correct.
Then the other concern would be that of palm M, that is of malignancy. That too, like about 10%. Though the most common cause for postmenopausal bleeding would be something like a senile cause, atrophic endometritis. But though there is a risk for malignancy, about 10 to 20% we can get malignancy in case of postmenopausal bleeding, unlike in case of an abnormal uterine bleeding during the reproductive age.
Okay. Thank you.
Thank you.
This is a question I'm going to ask both the consultants to answer, Dr. Pallavi Srivastava and Dr. Shilpa Rao. Should you investigate all PMB and your rationale for that? Dr. Pallavi, to go first.
Good evening, everyone. Yes, ma'am, I think we should investigate all PMBs because although it's only 10% of the times that we can have a malignancy, but even those 10% can be saved if we start investigating all PMBs. So yes, I think all postmenstrual bleeds should be investigated by either TVS or whatever is available to us, whatever is easily available to us. But yes, we should investigate all PMBs.
Absolutely. Agreed. Dr. Shilpa Rao, what is your opinion about investigating all PMB and why?
Ma'am, she's not able to join because she has emergency section.
Okay. Can I ask you to take it, madam? Dr. Shichi James. Thank you very much.
Yeah. So I agree with Dr. Pallavi because since there is an incidence of 10% and we should not leave a single case of adenocarcinoma undiagnosed CA uterus. So it is necessary that we should investigate all PMBs falling within the guidelines as to whom we should go further, and especially if they have comorbidities like diabetes, obesity, hypertension, any familial syndromes, they should be investigated further if they're on any hormonal therapy, early menarche. So we have to look into the risk factors, and plus the investigations which we'll be discussing later will help us in deciding.
Absolutely. The important aspect here is, though only 10% of postmenopausal bleeding would yield an answer in the form of endometrial carcinoma as the cause for the bleeding, 90% of endometrial carcinoma will present with postmenopausal bleeding. That itself makes it a justified thing to investigate all PMB. And thank you for that consensus on that. Why is it necessary? We've already answered. That was your question. So because this is the reason, and the probability of endometrial carcinoma with PMB is about 10%. However, this increases with the age, with an estimated cancer risk of 50% in women over the age of 70 years presenting with PMB. That's also very, very important. And this is the age-related risk factors independent of HRT, and rightly mentioned so by Dr. Shruti J. It is important to profile our patients depending upon the metabolic risk factors such as diabetes, presence of PCOS, liver disease, and hypertension, because it creates an environment of excess estrogen excess in the body, which is the reason for the endometrial cancer and certain genetic syndromes where there is a preponderance risk of nearly 30 to 50% when you look at the presence of Lynch or Cowden syndrome. When do you need to see them fast track, like as soon as immediately possible, Dr. Khatija? What are the indications why you would see them ASAP or investigate ASAP?
So we need to see them emergency, especially when the cases that of true post bleeding. That is, once the patient has got her bleeding cessation for about 12 months without any case of like hormone management, or when she's not pregnant. And then when there is an incidental detection of an endometrial thickness of 10 millimeters, or even if it is less than 10 but with concerning features like heterogeneity or increased vascularity, that raises a suspicion, then we need to see her. And also patients on tamoxifen with bleeding, and those patients on hormone replacement therapy with risk factors, that is like either she is obese with a BMI more than 40, or she's on continuous prolonged sequential hormone replacement therapy for more than 5 years, or on unopposed estrogen, or when there is a familial risk factors like when there is a BRCA1, BRCA2, or Lynch or Cowden syndrome. In all such cases, we actually need to see the patient and need to investigate.
Thank you.
Thank you.
So this is the reason why you would fast track them and see them as quickly as possible. So don't forget the BRCA 1 and 2. So history of breast cancer or colonic cancer or family history of these are also very, very important. And patients with incidental thickening of endometrium more than 10 millimeters. So that is the cutoff where there is an asymptomatic thickening of endometrium more than 10 millimeters are also important aspects where you would investigate immediately and get on with the management as well. So what is the imaging choice? Dr. Divya and Dr. Majaveen, you can take these questions. What would be your choice and why do you so? Why do you think so? Dr. Majaveen, if you're still traveling, let me know.
Yes, ma'am. Yes, ma'am. I can answer this.
Thank you.
Yes, ma'am. The first non-invasive, and it's a reasonable first non-invasive step in diagnosing postmenopausal bleeding is transvaginal ultrasound compared to transabdominal ultrasound. And we can have a cutoff value. We can take the cutoff value of 4 to diagnose it. But the thing is, it has a higher sensitivity and also specificity. But it should not be an ideal imaging modality. It should not be an ideal tool for predicting the disease. For predicting the disease, we should go for endometrial sampling.
You mean diagnosing the disease?
Yes, ma'am. Yes, ma'am.
Confirming that it is.
Evaluation,
the
for
cause,
evaluation of a postmenopausal bleeding.
This is more like a screening tool to triage your patients. That's what you're trying to tell.
Yes,
Thank
ma'am.
you.
Yes,
Thank you. Dr. Divya, your opinion on these modalities. Why would you, which is one which you will never use, which is one you would try to use most? That is what I'm trying to get at.
Good evening, ma'am. Thank you for this opportunity for giving me. Ma'am, I would like to prefer transvaginal ultrasound first preference, and transabdominal pelvis in case there is a patient is obese and all those. Transvaginal is preferably best, ma'am. MRI I would not use, ma'am, because it's more expensive, cost effective wise, if I would say. And transvaginal, the cutoff of 5 we will take, and accordingly we will go for biopsy, endometrial biopsy, ma'am.
Okay.
I just want to add a point, ma'am. Here, MRI, diffusion weighted MRI can be used, but the thing is, it can differentiate only the endometrial CA from a other endometrial disorders, but it should not give any further added details to the endometrial carcinoma invasion. The depth of myometrial invasion, other things can't be detected through MRI. So the main best tool is transvaginal ultrasonogram.
No, MRI is also used for staging. If there is a confirmation of endometrial CA by histology. So these have different roles in the evaluation of postmenopausal bleeding. The transabdominal ultrasound in the current scenario where obesity is a bigger pandemic will not be a great tool to evaluate the endometrium in close quarters. So it may not be the preferred modality of imaging. Transvaginal ultrasound is the screening tool which gives lot more information in close proximity to image not only the endometrium, the endometrial myometrial interface, the presence of other pathologies, and to evaluate the adnexa as well at the same time. MRI will tell us about invasion in terms of the staging once the endometrial pathology is confirmed in case of endometrial CA. We also have to understand there are limitations in certain patients where transvaginal ultrasound will not be tolerated or cannot be performed, like in a nulliparous woman or an atrophic vagina where the access to the vagina is kind of limited, then MRI would be preferred. So this is the main role for the ultrasound. It's more accurate than the transabdominal ultrasound with regards to the transvaginal ultrasound. It's an effective means of triaging. And I would like you to all concentrate on the last point, that a sensitivity with a cutoff of 3 millimeters, there will be 98% sensitivity, with 4 millimeters, 95%, and with 5 millimeters, 90%. The Scottish guidelines include 5 millimeters, whereas the rest of the guidelines include 4 millimeters. For benefit of doubt, we will keep 4 millimeters as the cutoff for the endometrial thickness as far as the transvaginal ultrasound is concerned. So, going on to the same question to Dr. Vandana Grover and Dr. Khatija, what is your cutoff for endometrial thickness before which you would evaluate further?
Ma'am, as you said, we all know the 4 mm is taken as a cutoff in our scenario. And but if the patient has been on HRT, then the values would be different, because if the patient is on continuous HRT, then maybe 5 mm. And if she's on sequential HRT, then the cutoff can be even more, around 7 mm. So, but 4 mm should be taken as a cutoff for.
Thank you.
normal
And Dr.
population.
Khatija, any different views on that? Any
Yes, ma'am.
particular caveat? Yeah.
When 4 mm is the standard which we take as a cutoff for the endometrial thickness. But madam, my concern is like whether suppose she's having a 3 mm endometrial thickness but a fluid in between, then we should go for the sampling there.
Very pertinent point. Fluid in the cavity, even with a 1 millimeter endometrial thickness, I have procured endometrial CA, where in the form of the irregularity. So it is just not the endometrial thickness, it's the other aspects in the endometrial cavity, which should be a alarming feature for us to proceed further. Could you elaborate what those features would you be looking for, Dr. Khatija?
One thing is, madam, whether there is a homogeneity, whether any particular foci, whether it is, then the other thing is already mentioned, whether there is fluid. And in all such cases, we need to go for a further investigation.
Yeah. So if there is above 3 millimeters or 4 millimeters, definitely go for further evaluation. Lesser than that, do not do any invasive procedures, because that pretty much rules out an endometrial CA. But fluid in the cavity, irregular endometrial cavity thickening, or the lack of the endometrial interface with the myometrium, and importantly, vascularity on Doppler color flow will all point out to a possible neoplastic etiology within the endometrial cavity, which will need a hysteroscopy and further evaluation with the biopsy. So this is the TV scan criteria which is used. Ultrasound cutoff. Endometrial thickness is 4 millimeters for the non-HRT group and 5 millimeters for uterine bleeding on continuous HRT group and 7 millimeters for the sequential HRT group. So this is something we could take as a guide or as a rule of thumb for investigating further by invasive procedures. So, Dr. Shuchi Jain, can you explain what you're seeing in the image both on the left and on the right? The left has already got the answer there.
Yeah, the left is a picture in a sagittal plane with a thin endometrial echo. Whereas on the right side, we can see thickened, but the endometrium is still regular. And if it is less than 3 mm, we need not worry much about it.
Yeah, you're right. Absolutely. Thickened but regular ET. There is no irregularity. There is a proper delineation of the endometrial cavity from the myometrium. You can see it as a much more echogenic area compared to the myometrium. These are kind of reassuring features from that point of view. Right. Absolutely. Thank you for that. Dr. Pallavi Srivastava, can you look at these images and tell me what's going on the left and the right?
Yes, sure, ma'am. On the left, I think it's increased endometrial thickness, which we are looking for in a PMB patient. And that was on the left, and now on the right, I think it's a polyp. Tamoxifen users, tamoxifen, which is used by breast cancer patients, that usually causes endometrial polyp. So we also have to look for endometrial polyp, and we that depends if we need to investigate them or not. But yes, endometrial polyp is also a sign on TVS.
Why do you say it is a polyp? And how would you confirm it could be a polyp, if at all you needed to?
Ma'am, confirmation can be done only on hysteroscopy, but when it's a whitish homogeneous structure in between the endometrium, then we can say when the echo is a bit hyper, so we can say it's a polyp.
Yeah, hyperechoic area, which is concentrated in one particular area as a focal thickening, can be that. And we can use saline sonography also to find out confirmedly on an imaging whether it is a polyp. Thank you. Cystic spaces and polyps generally mean benign changes. Dr. Nisha Marhata, your views on this? Dr. Nisha? Are you the one doing cesarean? Sorry.
Good evening.
That was Dr. Shilpa, yeah.
Yeah. Oh, sorry. Okay.
I got disconnected in the beginning due to
No problem.
These
Do you agree with this? Do you have anything else to add to this? This is what the question is.
cystic changes in the endometrium with hyperplastic changes, and such features usually suggest some benign pathology. We can often see such findings often when we have patients whom we are treating with mifepristone for fibroids. Often we get these findings. This is very typical, looking typically like that.
Very nice. Could you elaborate more on that? Which medications which you commonly use potentiate the chance of endometrial abnormalities on imaging?
Tamoxifen is one of them, selective estrogen receptor modulator used in breast cancers, and mifepristone we often see when patients are taking it for prolonged 2-3 months, and then they come up with their scans and showing and they have amenorrhea of 2-3 months, and then we get a scan, then we typically see this kind of picture.
Absolutely. Thank you very much for that.
Thank you, ma'am.
I think Dr. Shuchi Jain will sit in for Dr. Shilpa. What is this you're seeing? What are the features you're seeing? And what is it pointing to potentially? On the left and the right.
Yes. On the left, we can see a thickened endometrium with loss of transformation zone, which is irregular also. So it goes in favor of endometrial cancer. And on the right side, we can see increased vascularity, which on Doppler, which is again a sign of malignancy. So both these pictures make us feel that probably we should go in for a biopsy and then treat her accordingly.
Yeah, a visually directed biopsy rather than a blind curettage. We've stopped doing blind curettage. It is a hysteroscopic, visually guided biopsy of the abnormal areas. Very, very important, especially in an atrophic cavity when there is a focal thickening. It is better to guide your biopsy on visualization. So, yes, very, very important. Generalized thickening, echogenic areas, along with lack of demarcation or interface between the endometrium and the myometrium, and irregularity in the interface with abnormal color Doppler flow patterns, all point to a potential malignant etiology within the endometrial cavity. So, thickened irregular margins and increased vascularity. Okay, a mini debate. Dr. Divya and Dr. Ashimira, tamoxifen, boon or bane? Dr. Divya, you give me 3 points why it's boon. Dr. Ashimira will counteract you saying why it is a bane. 3 points each, just to make this more interesting. That's all. Otherwise, I'll be talking too much. Dr. Divya? Dr. Vandana, would you like to take that question?
Yeah, ma'am, tamoxifen is a very good drug for patients of CA breast. Hello, am I audible?
Yes, absolutely.
Yeah.
Absolutely.
But yes, it does cause endometrial hyperplasia. It can cause the polyps and can increase the chances of patient getting CA endometrium. So that is there.
Okay, but why is it a boon?
The chances of recurrence are significantly reduced by tamoxifen. So it is a big boon. The longevity is there and the quality of life is much better for the patient. So it is a boon for the patients of CA breast.
It is a boon for CA breast because it acts as an anti-estrogen in the breast tissue, maybe a mild weak estrogenic property on the endometrial cavity, but that is why we monitor them if they have problems. Dr. Ashimida, why is it a bane?
I do agree with doctor. Like it's a bone for CA breast cases, but if we consider CA endometrium, like it has a estrogenic effect on the endometrium, which can increase the risk of endometrial carcinoma. So it doesn't happen in all the cases. It happens only, even though it happens only in the 50% of the cases, but it can increase the risk of endometrial carcinoma.
Yeah.
And it can, like it in 8 to 36% of cases, it causes endometrial polyps and hyperplasia and other changes in endometrium.
Yeah, it's mostly polyps which are seen with patient cohort of tamoxifen and endometrial hyperplasia. 1 in 5 women treated with tamoxifen can show features of endometrial hyperplasia. And endometrial carcinoma is not as common as endometrial polyps or endometrial hyperplasia. So to dwell on this further, it makes the endometrium to appear thickened, irregular, and cystic. And multiplicity of these problems can be seen when imaging these patients. So normal endometrial thickness, despite tamoxifen use, 50% of those receiving tamoxifen have been reported to have an endometrial thickness of more than 8 millimeters. And it also dose dependent and duration dependent of tamoxifen. From 5 years now, majority of the breast CA patients have gone on to have tamoxifen for up to 10 years. Subendometrial cyst and endometrial polyps usually larger than that in untreated women. So sonohysterography, as I mentioned earlier, saline sonography may be useful for the identification because, as I told earlier, more than a third of these patients have only endometrial polyps. It is a very reassuring thing to see the polyp because these are not going to be cancerous, unlike the other one. So, the next important consensus question: do all women on tamoxifen need screening transvaginal ultrasound? Consensus between Dr. Vandana Grover and Dr. Shuchi Jain. So I have a patient 6 years now on tamoxifen. She's not symptomatic at all. She is an intact uterus. She does not complain of any symptoms. Should I be doing every year or every 6 months scan? What is the consensus?
It is not mandatory to have a transvaginal scan for all the women who are on tamoxifen, but only if they are symptomatic. If they have any kind of blood mixed discharge or bleeding or any other this kind of symptom, only then we need to investigate them.
Dr. Shuchi Jain, what is your view on this?
We normally do a 6 monthly scan to look for the endometrial thickness.
Okay.
If it is
Even
less
if they
than
are
10,
asymptomatic.
yeah, if it's less
Okay.
than 10 mm, we don't do anything about it.
Ha.
But suppose it is going more than 10 mm, then we do take a call on this.
Understood. Dr. Omana ma'am, would you have an expert view on this particular question?
Yes. I also feel it's better to screen them at least once in 6 months so that we will not miss. miss actually.
Okay. Okay. So, ultrasound screening of asymptomatic patients taking tamoxifen has been shown to be problematic due to the number of false positives. So, routine ultrasound is not typically recommended. It's from the ISG as well as the British Society of Gynaecology and Ultrasound Imaging. And if the patient is not experiencing bleeding, it has been proposed that patients taking tamoxifen who present with vaginal bleeding should go directly to hysteroscopy and endometrial biopsy rather than triaging them with a hysteroscope, because we need to find out and treat if there is a polyp or otherwise. So these are the tamoxifen induced changes which are there earlier. Sorry. So as you can see, the subendometrial cyst on the right side and the irregular pattern with the polyp-like feature is more suggestive of tamoxifen effect with a generalized thickening at the same time. So when do we actually scope? You might have caveats for this, but let me know when you will scope. Dr. Khatija, you can take the first two, 3 mm, 4 mm.
4 mm.
4 mm. 3 mm, when will you scope?
When, if suppose there is fluid in between or any, as already mentioned, when there is something irregular, increased vascularity, more suspicious of malignancy, then more of a targeted.
If she had postmenopausal bleeding and 3 mm, would you scope?
Let's
Near
check.
to 2.
But
will you scope?
Yes, ma'am, we have to do. Yes,
Yes.
ma'am, we have to do. Yes, we have to do, because atrophic, even with atrophic endometrium, there is a higher
Correct.
chances for endometrial CA.
Yeah.
Because
If
of
3
other
mm is an
non-endometrial.
asymptomatic and incidental finding and it's only 3 mm, you don't need to scope. But 3 mm with postmenopausal bleeding or with fluid in the cavity, you will scope. Thank you. Otherwise, 4 mm will be the cutoff. Correct. 5 mm, 8 mm, 10 mm. When will you scope? Dr. Divya. All?
All, ma'am.
Everybody?
5 mm if at
5
all she's having any postmenopausal bleeding. 8 mm if she's also on some drugs or anything. Yes, ma'am, for everybody.
So
5
5 mm
mm if
is
she's on continuous HRT.
HRT, yes, ma'am. Or
Yeah.
if she's on.
If it's incidental finding with no HRT, say
Then we go
a
for 10
70-year-old.
Yeah.
Exactly. If she's a 70-year-old and asymptomatic, annual checkup endometrial thickness is 5 or 8, I wouldn't do anything. But if they are
Anything,
on
ma'am.
hormone
Yes.
treatment, I would scope. But if it's 10 mm, or even if it's an asymptomatic thickening, incidental finding on master health checkup scans or regular screening, I would go and scope. Have we all agreed to that?
Yes, ma'am.
Thank you. So endometrial thickness is an effective means of triaging, and ultrasound cutoff we've already seen. It will be hysteroscopy and most patients will be discharged by that, and 6 to 10% will have polyps. What to do with an asymptomatic endometrial thickening? How do we go about it? What do we tell the patient, literally?
Ma'am, in asymptomatic endometrial
Dr.
thickness,
Pallavi.
it depends how much is the thickness and the quality of the endometrium. If the thickness is well within 10 mm and the quality, I mean the endometrium looks fine, then we need not do anything much. And also we have to look at the high risk factors, or if she's taking HRT and all. If the endometrium is fine, and as you just told us that if it is more than 10, then irrespective of anything, we'll be proceeding further. But if it's less than 10, we'll look for many factors. If she's on HRT, what is the vascularity, how if it's regular or irregular. So looking at those findings. Otherwise, if there is no high risk factor and if it is just 4-5 mm, we need not do anything for the increased endometrial thickness.
Yeah. Thank you. I want to clarify this particular thing. For patients who we intend to screen for endometrial cancer, say because of their PCOS, the risk factors, or a family history, TVS is not a recommended screening tool because 93% can show false positive result. However, transvaginal ultrasound is the choice of screening tool for any patient coming in with postmenopausal bleeding. So there is a difference between how we apply the use of transvaginal ultrasound. It's not a screening tool to detect or predict the chance of endometrial cancer. And it's also known that nearly 1/5 of the patient can have a baseline thickening of more than 4.5 millimeters, even in the postmenopausal group, but their incidence of endometrial cancer will be less than 1%. So, all endometrial thickness should not be routinely biopsy because it has its own false positive and false negative rate. So, in asymptomatic women, endometrial thickness of greater than 4 to 5 millimeters should not be used as a threshold. And prevalence of endometrial atypical hyperplasia in cases with thickened endometrium of 10 millimeter without postmenopausal bleeding. So that is the time which we all agreed as well. And malignant risk of 2.3% in endometrial polyps and postmenopausal vaginal bleeding, which is why we directly deal with these polyps with hysteroscopy. We showed in the earlier slide that if a patient with tamoxifen comes in with bleeding, we go ahead with hysteroscopy and evaluation of the endometrium. So, what is the final take home point with regards to all this, Dr. Nisha?
Ma'am, the take home message should be that we should look into the thickness as well as some additional features on ultrasound like increased vascularity, whether there is fluid and all. Also should keep in mind the clinical presentation of the patient, whether she is symptomatic or not, as well as whether she's taking HRT or she's not taking HRT or any other drugs, just to quantify that at what level of endometrial thickness should we go for a invasive testing and keeping endometrial CA in view. So like at endometrial thickness of 4 mm in a non-HRT patient with who's having postmenopausal bleeding, we should screen her further. And for sequential HRT cases, we can take it up to 7 mm thickness. And for combined HRT cases, 5 mm cutoff is usually taken.
Okay. So, proceeding on to some of the case discussions we put together, a 55-year-old nulliparous lady with irregular postmenopausal bleeding. Many of them think they are still not menopausal, but they continue to have once in 4 months, 2 days, and then again 3 months or 2 days, something like this kind of pattern. So, between these three doctors, Dr. Vandana, Dr. Shuchi, and Dr. Divya, what details will you ask for in history? What will you look for in clinical examination and investigations, which we are going to order? Dr. Divya? Anybody else?
Yeah, I'll take it, ma'am. So,
Yes,
as we
please.
discussed earlier, age at menarche and late menopause are high risk factors. We would like to know about unexposed estrogen exposure during her reproductive life. So, any history of anovulatory bleeding, PCOS, if she has received any treatment for it, any history of infertility, any history of diabetes, hypertension, or she's had perimenopausal bleeding, that is even before her menopause, she's had irregular bleeding, and family history of uterine cancer, colonic or breast cancer to look for the Lynch syndrome. So these are all the histories we would like to dwell into to find out what is her risk of having endometrial malignancy and then proceed further.
Excellent. Dr. Shuchi,
Yes.
This is an examination. What would you concentrate on?
Yes, ma'am. So general examination, we need to see her BMI because obesity is a major risk factor. Then if she is bleeding a lot, whether she is extremely pale, her blood pressure for hypertension. At the same time, abdominal examination to see if the uterus is enlarged or we have any organomegaly or ascites, though very rare, could be present in a few women. And adnex uterine mass, uterine palpation plus adnexal, because sometimes even ovarian tumors can have postmenopausal bleeding. So, I mean, we should do a thorough clinical examination of this patient.
So, investigation, Dr. Vandana Grover.
Initially, the basic blood investigations will do the CBC, the thyroid function test, and she's to rule out diabetes and all. We should, and most important investigation is ultrasound, transvaginal ultrasound of the pelvis, and it should be followed by endometrial biopsy, whether it's by using a pipple or hysteroscopy, but a biopsy is a must.
Thank you. A 54-year-old mother. There was a question at the last, if both of you want to take, if it's atypical hyperplasia, what would you want to do? And a 55-year-old lady.
For a total abdominal hysterectomy with a bilateral salpingo-oophorectomy, or at least a bilateral salpingectomy if she wants her ovaries to.
A 55-year-old.
But 55, I think we can go for a 60 is the cutoff in some guidelines. So, but
No,
with endometrial
with
hyperplasia, I
endometrial
would personally
hyperplasia, yeah.
go for a oophorectomy.
Yeah. I would always do a mammography in these patients because they are index case of estrogen excess already. So combine it with mammography during the investigation as well. This is something for us to remember. Thank you for that. Case 2, a 54-year-old mother of one child presents with postmenopausal bleeding, the gynae OPD. Between Dr. Pallavi, Dr. Nishan Majhabi, how will you evaluate clinically? Investigations you will order. And this is the final diagnosis. What else would we need to do in therapy?
Yes, ma'am.
Yeah. Dr. Pallavi?
Yes, ma'am.
Thank you.
Ma'am, again, we'll take a thorough history about her obstetric history, whatever it was, how if she was PCOS or not, if she have had any secondary subfertility issue or anything, and now the kind of bleeding, for how long she has had the bleeding, the amount of bleeding, frequency, duration, and everything. The predisposing factors, as I mentioned, if she has had any medical or other history related to infertility or metabolic syndrome, then a detailed examination of BMI, blood pressure, and the local examination of the size of the uterus and any adnexal masses, pellar, and everything.
Okay.
Then we move on to transvaginal ultrasound, which is the mainstay, where we see the thickness, if she has any polyp or any adnexal masses, and then if required, endometrial aspiration using PIPL or maybe DNC if we cannot focus on the lesion.
Yeah. It's stage 1 endometrial carcinoma, no lymphovascular space invasion, grade 2. It's endometrial carcinoma. What will be the further plan with the current FIGO and the molecular studies? What is
So this
important?
patient comes under a low risk category. So we no need to give any adjunct therapy. We can go just for hysterectomy. No need for any adjunct therapy in that patient. In this patient, yes.
The most important thing, you would also include what it said in the MRI with regards to invasion and everything, and the final histopathology as to the grade of the tissue, the histological type. If it comes back as serous or clear cell or sarcomatoid, it automatically escalates to become a high risk, which will need further treatment in terms of adjuvant therapy. That is the take-home message. And we also do important molecular studies. Can one of you elaborate the molecular studies which we need to give apart from the immunohistochemistry? What are the 3 things which we look for? Pole mutation.
Mismatch repair genes.
Mismatch repair genes.
The microsatellite instability.
Correct. And P53 mutation.
P53 mutations.
If these are present, it again grades it off as a high risk, and they will need further chemotherapy or radiotherapy, depending upon the situation with regards to that. And if it's a low-grade tumor, if it's stage 1A, low-risk tumor and a low-grade tumor, if it's ER positive, it still remains a low-grade. If it becomes ER negative biologically, then automatically it upgrades itself into a high risk. These are important modifications with regards to the FIGO staging based on molecular studies and immunohistochemistries, which we need to be aware to maximize the survival of these patients and to minimize the remote recurrences which can happen with endometrial CA. This is something I wanted to emphasize with regards to the surgery and the follow-up as well. The final case, a 56-year-old para 2, light 2, postmenopausal for 10 years, postmenopausal bleeding for the last 2 weeks. How we are going to evaluate the patient, Dr. Ashimida? We have 5 minutes and we'll try to wrap up.
Okay, ma'am. Like in the previous cases, we will be taking a detailed history, and in this case, she is having pain. So we need to like get more details on the pain And further in the examination, we will be focusing on the abdominal examination, whether she is having any mass, adnexal mass, along with the per abdomen and per speculum examination we do. And in this case, since she is her uterus is bulky and she is having a 10 into 10 centimeter mass in the right iliac fossa. So we will be doing for the visualization of the two mass, we will be doing the ultrasound initially, and in which we will see the details of the cyst.
Absolutely. So it is already showing an endometrial thickness which is quite thickened of 22 millimeters and a right adnexal complex, which is again quite big, with para-aortic lymph nodes. What would your diagnosis be? How will you proceed?
So in this case, it could be a malignant one. So we need further malignancy, metastatic workup. And since there is a adnexal mass, I would like to send tumor markers like CA125 and inhibin, because in granulosa cell tumors, estrogen secreting tumors, inhibin could be raised, or CA125 can be raised in epithelial tumors as well. So I will send apart from other investigation tumor markers in this case.
Yeah, the basic idea is to see whether the estrogen excess from a granulosa cell tumor is the one causing the endometrial thickening, and that is why inhibin is justified, and the CA125 to rule out an epithelial tumor. And we also need to know whether it's a primary, which is kind of metastasized to the ovaries, or two coincidental primaries, which is why we do these tumor markers apart from the histological diagnosis, and the PIPL confirmed an infiltrating carcinoma. The pre-op evaluation and proceeding to whatever we needed to do along with pelvic and para-aortic lymphadenectomy. The HPE report is this: type 3 endometrial CA with a papillary serous type, which I mentioned earlier, with metastatic deposits in the left ovary and left tube. Look at the right ovary, it's a serous cystadenocarcinoma, and the nodes are positive. And para-aortic also nodes show positivity with metastasis. It's stage 3C2 with regards to the endometrial CA, which is of a high-grade type because it is papillary serous.
So
What
this
next?
case needs radiotherapy as well as chemotherapy.
Okay, so this is an adjuvant therapy which is going to need, because it's already metastasized quite well, and para-aortic node is the final sentinel one where the recurrences could happen. So now on chemo RT. 59-year-old postmenopausal CA breast operated and post-op treatment with tamoxifen for 5 years. Endometrial thickness of 2 centimeters. How will you manage this patient, and any role for prophylactic progesterone therapy? Dr. Divya, Dr. Majabi.
Yes, ma'am. The first thing is we have to ask whether the patient is having symptoms like postmenopausal bleeding. Since it's an ultrasound finding of more than 2 centimeter, if if the patient is having symptoms of postmenopausal bleeding, definitely we have to go for endometrial sampling. And also this level of endometrial thickness of like more than 2 centimeter, more than 10 mm.
Itself needs.
It needs endometrial sampling.
Absolutely.
Yes, ma'am.
Absolutely. Absolutely. And we do not put in prophylactic LNG-US in patients, especially on tamoxifen therapy, because Mirena itself has effect of progesterone on the breast cancer risk, and we do not want to go against the oncology care pathway for this. In fact, the latest guidance say that if a patient is on LNG-US and there is a family history of breast CA or they have BRCA positive, they need frequent mammograms to be on surveillance rather than ignore the slightly increased risk of even LNG-IUS on the breast cancer risk. So level of risk of endometrial cancer is basically dose and time dependent with regard to this one. So we've gone through all this already in the previous slides, so I'm just going to skip this through. Thank you. I think we are very good with time management. Thank you all panelists for taking these questions at a good pace and reiterating all the take-home points. May I now request our expert, Dr. Omana, to give her expert opinion on anything and for reiterating the take-home points as well.
Yes, madam. It's a very, very wonderful webinar with so many take-home messages. Let me first congratulate our Sambat Kumari madam for organizing this Pinnacle episode 19. And I feel she's a very lovable person with coming out with all practical tips for the practicing obstetricians. Now, my thanks for including our Wynot Society in this great venture. Now, I have no words to congratulate Dr. Madhumati, who has taken all the pains to arrange this webinar. And I think in postmenopausal bleeding, you have already covered whatever is available. I congratulate you there, Masi. Then I congratulate Dr. Meera for your wonderful arrangement, wonderful question and answers. And I think these slides can be all the societies can utilize these slides because it covers everything to speak about postmenopausal bleeding. I also had an advocate with 5 mm endometrial thickness with absolutely no symptoms. She came for abdominal pain actually, and 5 mm thickness, 3 years menopause. We did an curettage. We found it is endometrial carcinoma. Total hysterectomy was done, so adequate treatment was given. And after 5 years also, every time she tells me, Madam, you have given my life back. So I think any postmenopausal bleeding has to be evaluated. Even if now we have given the correct guidelines, 4 mm, 5 mm, 10 mm like that. In periphery especially, the patients will be very much reluctant because they have no symptoms. We are doing scanning for something else and we are getting the endometrial thickness. So convince them is an obstetrician's requirement. So telling them, even if she was an advocate, why madam, I am having no symptoms and the thickness is only 5 mm. They'll go to Google and they'll find so many things. So I think we have to take pains to convince them because it is so rewarding that even after 5 years, every year she goes and investigate and coming back, sending me message, madam, I am okay. So that is some great thing in a doctor's life, isn't it, madam? Especially in obstetricians.
Absolutely.
And today's webinar, I think we have covered everything, as well as in adolescent bleeding, as well as postmenopausal bleeding. And I think we will circulate these slides. We are again waiting for the next webinar with this practical topic. Not very hi-fi, but we get all the hi-fi points also. Thank you very much. Thank you very much for
That's a very
including us.
important point for take home. We convince our patient to evaluate, not for
Yes.
hysterectomy.
Yes,
So that is the
evaluate,
point.
evaluate.
Thank you,
Yes,
madam.
yes.
Thanks a lot.
Okay.
Thank you,
Thank you.
panelists, and thank you, Madhumita, and especially Sampath Kumari ma'am for this wonderful opportunity to meet all
Thank
of
you so much, dear Meera ma'am, Omana ma'am, and all the dear panelists for such a wonderful panel. And I think ma'am Sampath ma'am was supposed to join. I think she's not yet come
She's
from
not
flight.
landed yet.
She's not
She's
landed
not
yet, so I might try
landed.
calling. Phone is not reaching.
Yeah, she's not landed.
So I think as everyone is aware, ma'am is standing for president of Foxy. She's standing for the next year for president of Foxy. So I kindly seek all your valuable votes for Dr. Sampath
Definitely,
Kumar.
ma'am. All the best.
Yes,
I'm
ma'am.
sure
Thank you
you'll
so
get all the best.
Please.
Sure.
Yeah. Thank you, madam.
Thank you so much, ma'am. Thank you so much.
Thanks, organizers. Thanks, Meera ma'am.
Thank you so much.
Thank
Wonderful panel. Yeah.